Now the next I will welcome Dr. Siddhartha Odhikari from Rehabilitation, consultant physiatrist, to take the dais.
Good morning. My topic is breathing beyond boundaries, the role of pulmonary rehabilitation in ILD. ILD, interstitial lung disease, represent a large number of conditions that involve the parenchyma of the lung, the alveoli, the alveolar epithelium, the capillary endothelium, and the spaces between those structures, as well as the perivascular and lymphatic tissue also. ILD has been difficult to classify because more than 200 known individual diseases are characterized by diffuse parenchymal lung involvement, either as the primary condition or as a significant part of a multi-organ process, as may occur in the connective tissue disease like rheumatoid arthritis or SLE, etc. In pathophysiology of ILD, there is thickening of inflammation of the interstitium, leads to a restrictive ventilatory pattern and impairment of gas exchange. Destruction of the pulmonary capillary bed may also occur, and contributing to ventilation perfusion mismatch and oxygen diffusion limitation also. Circulatory limitation results from pulmonary capillary destruction and vasoconstriction, leading to pulmonary hypertension and cardiac dysfunction. In clinical feature, there are exertional dyspnea mainly, with fatigue, dry non-productive cough, hemoptysis sometimes, with exercise capacity limitation. Pulmonary hypertension may occur sometimes. For ILD rehab, for us there are a few goals like reduce dyspnea and fatigue, improve exercise tolerance and daily functioning, enhance quality of life, and decrease hospital admission and healthcare cost also. For assessment part, we can use 6-minute walk test or dyspnea scale, which is modified Bose scale commonly, spirometry, and quality of life questionnaires. For pulmonary rehab, medications have few role. With it, patient education, psychological support, nutritional support, and exam therapy like oxygen therapy or non-invasive ventilation may be useful. But now I am only discussing about breathing exercises, endurance training, and resistance exercises. Breathing exercises, diaphragmatic breathing and pursed lip breathing is mainly used for this patient. And incentive spirometry is very useful, and with it increasing lung volume, techniques like respiratory muscle training strengthen and muscles involved in the breathing, increasing the lung capacity and reducing breathlessness. The aerobic exercise has lots of benefit like increased lung capacity, reducing exertional dyspnea, improving exercise capacity through increased type 1 muscle fibers, decrease oxygen requirement for same workload, and increase cardiac output with decrease in heart rate. For framing the aerobic training protocol, we can use the walking, treadmill, or cycling. Frequency usually 3 to 5 days per week, intensity 60 to 80% of maximum heart rate, and duration 20 to 40 minutes per session according to the condition of the patient. If patient can't tolerate continuous training, interval training can be used, where after 1 minute training, 1 minute rest can be given, and supplemental oxygen also can be added. If Borg dyspnea scale less than 4 and heart rate less than 85% of age predicted, we can increase the intensity and duration of the exercise in 1 to 2 weeks. For monitoring of the during exercise, heart rate is most important. In maximum heart rate should be calculated, and 60 to 80% of that we can go up to that, and modified RP scale for fatigue, and our aim is from 4 to 6. Saturation 88 to 90%. There is no oxygen supplementation needed, but if fall below 88%, we have to give oxygen supplementation or have to stop the exercise. And blood pressure should be systolic less than 220 and diastolic 110, and MET usually 3 to 6, which is moderate exercise. And for strengthening exercise, lower limb strengthening, especially quadriceps, is preferred according to the evidence, which is 2 to 3 times per week, and start with isometric followed by isotonic. And for muscle strength measurement, isokinetic dynamometry is gold standard. There are a few red flag signs when we have to stop the exercise. In ILD, we have a few special consideration like in consideration of pulmonary hypertension, patient may exacerbate symptom during exercise. For that, oxygen supplementation should be ready. And people with connective tissue disease like related ILD frequently have MSK limitation that may require modification of the standard exercise prescription because there is joint pain and low back pain. And take home message, pulmonary and it is recommended in every stage, and it is evidence based protocol, and which is not only chest physiotherapy because ILD is not limited to only lungs. Thank you.
Thank you very much.
Thank you, Dr. Odhikari.
All the salient point given cover.
Thank you. Now we conclude the session.